to have Dr. Eric Klawiter today. So Eric is an assistant professor of neurology at Harvard Medical School and an assistant neurologist at Mass General. And he's specialized in MS and other related diseases such as neuromyelitis optica. So Eric did his medical training at Sanford School of Medicine in the University of South Dakota. And then he completed with a residency at Barnes-Jewish Hospital and WashU in St. Louis. So as I said, Eric is very interested in MS in particular and taking advantage of advanced neuroimaging techniques such as MRI, and he's pursuing some developments of quantitative metrics to basically better characterize these diseases. So today he's going to talk about imaging correlates of cognitive dysfunction in MS.
Thanks, Julian. It's a pleasure and an honor to talk to you today about some of the work that we're doing to better diagnose and treat multiple sclerosis. So what I will do today is to first give a brief introduction on MS for those that are less familiar with that disease, and then move into what's been done so far in using neuroimaging to specifically look at a specific symptom or manifestation of MS, which is cognitive dysfunction. And then I'll bridge into some of the work that's been done looking at specifically corpus callosal atrophy in multiple sclerosis, and then resting state functional connectivity studies in MS, which there are a few in work that we're doing as well. So MS is a classically thought of as a demyelinating disease, which is neurodegenerative. And the diagnosis of MS, we think of it as a relapsing neurologic disease. So patients will have distinct new neurologic signs and symptoms, and then periods of relapse. And this is in the majority of patients with MS. And these are a result of lesions, demyelinating lesions that arise in the central nervous system, in the brain, the optic nerves, as well as the spinal cord. And these are disseminated over time, and by definition without an alternative explanation. And so the diagnostic criteria for MS has actually evolved over time. We are trying to diagnose patients earlier now so that we can confer the benefit of treatments to patients early on in their disease course, which is a change really over the last 10 years or so. And so the newest diagnostic criteria was just penned a year ago, and this allows for a patient to have one clinical relapse and then to use one brain MRI to make the diagnosis of MS. This is in converse to patients with primary progressive MS, where they have progression of neurologic symptoms in the absence of clinical relapses, and by definition over a one-year period. So that is a good segue into what we see with the clinical subtypes of MS. So as I mentioned, about 80% of patients with MS have relapsing remitting MS. So they have these, as we see in the upper left-hand corner, these distinct relapses followed by periods of remission. However, a percentage of patients after typically 10, 15, 20 years can move into another form of the disease called secondary progression. So in this case, patients stop having relapses, and really there's a decrease in the inflammation that we see pathologically, and they go into more of a degenerative phase of the disease, where signs and symptoms gradually progress without these relapses. And then as I also mentioned, there's a subtype called primary progressive MS, which is thought to represent maybe about 10% of all MS patients. And this will come up in some of the studies that we'll talk about. The very earliest form of MS is something that we call a clinically isolated syndrome. So these are patients that perhaps have just a single episode of optic neuritis, or an episode of transverse myelitis or inflammation in the spinal cord, and they have one clinical relapse and have a brain MRI that appears to be suggestive of multiple sclerosis. So these are patients that are at the very earliest stage, and more now we're starting to treat these patients that we think are going to go on to develop MS. So as I mentioned, MS is thought classically to represent a demyelinating disease, and this is the case. And so I show in the upper right-hand corner a cross-section of the spinal cord, and this comes from a pathology DTI correlation study that I did during my fellowship at Washington University, where we did a correlation of things like demyelination and axonal loss with DTI measures. But as we can see, there's this area in the cortical spinal tract of this MS patient where there's a loss of the Luxol fast blue stain, or the myelin. But in addition to demyelination, a very important component of pathology is axonal loss. And that's illustrated in the lower Bielszowski silver stain here, where we see relatively normal axonal density to the left, whereas there's axonal degeneration in a patient with MS then to the right. So cognitive dysfunction, it's one manifestation of multiple sclerosis. And while physical disability gets a lot of the attention with MS, cognitive dysfunction, I would argue, is actually equally important, and for several different reasons, which I'll mention. So it's very common in MS. So approximately 50% of patients with MS have some manifestation of cognitive dysfunction. And there are a number of domains that are affected in MS. However, the most prevalent affected domains include things like processing speed, episodic memory, information retrieval. And cognitive dysfunction can happen very early in the disease. So there are studies that have looked at these patients with clinically isolated syndrome and have found cognitive dysfunction. They have even found cognitive dysfunction in patients that have a new term called radiologically isolated syndrome. So this is even an earlier step where patients get an MRI for something like headaches and have, for all intensive purposes, a brain MRI that looks consistent with MS, although they haven't had clinical relapses. And although I will mention that that cognitive dysfunction is greater in the more progressive subtypes of MS. So it tends to be more common as patients have a longer disease duration. The reason that it's so important is that while this in some cases may be mild, in other cases cognitive dysfunction can have a major impact on quality of life and employment for patients. And the main reason that we're using MRI and to look at cognitive dysfunction is that really the etiology is unknown. So we know that there are these white matter lesions with MS, but as I'll show you, there probably is much more to the disease that we're learning about.
Eric, just a quick question on that.
Sure.
Do you think it's just a matter of sensitivity to our kind of behavioral metrics of cognitive dysfunction, this 50%, or do we actually think that some patients just truly are cognitively normal for whatever reason, others aren't?
Yeah.
Is it just,
Well, I think that there probably is. I think that there are patients that at least subjectively have no cognitive complaints, but will test abnormal on the testing. So there probably are very subtle cognitive difficulties that they subjectively haven't realized yet. I think there probably are a subgroup of patients that don't have a cognitive manifestation of the disease, but I think there probably are another subgroup of patients that from time to time realize that they have troubles recalling words. They don't have the same florid manifestations as, for instance, Alzheimer's disease, but they can be very subtle. So I think that maybe 50% is maybe even an underestimation of subjective complaints with patients. With imaging, with MS, the signs and symptoms depend to a degree on the location, the size, and the number of MS plaques. However, there is a real disconnect many times between what we see on the MRI and what a patient's appearance is. So we have patients that have a very severe looking MRI, but are walking around and have very little physical disability. On the other hand, we also have patients that will have new lesions that crop up on MRIs as we check serially, but don't have these relapses. So there are clinically silent lesions as well. So I think the way I think about the MRI is it is a piece of the puzzle when we're examining MS patients, and it's an important piece. So we also depend on the patient's complaints, their physical exam, but I think the MRI really has revolutionized not only the diagnosis, but how we follow these patients. With that, go ahead.
What's the origin of the MR signal, the MS plaque? What caused it to be bright?
Yeah, so and that's what we'll get into. So the flare or T2 lesion is probably most sensitive to things like demyelination. If we look at, so clinically, if we look at a T1 weighted scan, there's also hypodensities or black holes, and that probably correlates better with axonal damage. And there's a whole focus on imaging of trying to increase the pathologic specificity of various sequences, because frankly the conventional sequences are not that good at differentiating the degree of demyelination and the degree of axonal loss. And so axonal loss is actually important to quantitate because we think that that is more of a pathologic substrate for disability than demyelination, where there can be some degree of remyelination.
I think my question is, why does axonal loss cause T2 brightness? What's the reason for it? Is it more water, or is it more, what is the reason?
Well, with things like demyelination, there's also some associated edema, increased water content, which is reflective in the T2 lesion. What we'll see with this slide is that things like disability, though, do not correlate that well with the T2 lesion or the contrast-enhancing lesion. So in a group or a paper from 15 years ago, they've looked at the number of active lesions in MS and correlated that with changes in disability without significant correlation. So there, and as we'll talk about more, there is a real need to come up with better sequences for not only changes in disability, but changes in cognitive dysfunction, which I'll focus on with this particular talk. So the MS, in recent years, a lot of focus has shifted from this being a purely white matter disease to also a disease that involves the gray matter. And Caterina Mainero has been one that has been leading the charge in characterizing patients with regard to cortical pathology. So it's been known for perhaps 100 years on autopsy studies that the gray matter is involved with multiple sclerosis. And on top of the focal demyelination that we see in the white matter, there also is involvement of focal lesions and diffuse involvement of the gray matter. And so one study from 5 years ago looked at these, looked at autopsy brains and really did a good job of looking at the distribution of changes in the gray matter in MS. And what they found was that while there was evidence of cortical pathology in relapsing or remitting patients, this tends to be much greater in those patients with progressive disease, so those with secondary progressive MS and primary progressive. And however, that's on the autopsy. It hasn't, the ability to detect these cortical lesions has been poor with conventional MRI, or at least at conventional field strengths. And what Katerina has done is looking at ultra-high field at 7T, and with that increase in resolution, we've been able to better characterize cortical pathology. So in her first paper in neurology in 2009, she looked at 16 patients and found a total of 199 cortical lesions. And what's important about this finding is that the distribution of these lesions closely mirrored what is seen on autopsy studies as far as their subtype characterization. So lesions that are just contained within the cortex, those that are leukocorticoid or include both gray matter and white matter, and then also more diffuse subpial lesions. And in also work with Julian, they're developing more of a surface-based analysis of subpial T2 star weighted signal and have shown really for the first time that in vivo there is disseminated subpial change in MS patients. Now there's also work on trying to develop more cortical lesion-based sequences at 3T, as not every center has the advantage of a 7T scanner like we have here. And so the one sequence that has been looked at predominantly is a double inversion recovery image. And although this is fraught with some difficulties as far as agreement and artifact, there have been a couple studies that at least show that even though there may be some false positive results with these studies, that there is some correlation with cognitive dysfunction. So in one study, it was shown that cortical lesion number and volume, as well as gray matter atrophy, were different in MS patients that were deemed to be cognitively intact, or excuse me, cognitively impaired, versus those that were cognitively preserved. But there was really no difference in these two groups of patients between T2 lesion load and GAD-enhancing lesions. So in addition to the focal areas of cortical demyelination, there has also been appreciated atrophy. And what's been done over at the Brigham actually has been really great work looking at the differences between gray matter atrophy and white matter atrophy in MS. And it appears that atrophy within the gray matter is actually much more specific for things like disability, although probably both present some information for us when we look at some of the cognitive domains. So white matter atrophy correlated greater, at least in one study, with mental processing speed and working memory, whereas gray matter atrophy correlated greater with verbal memory, disinhibition, and euphoria. Another nice study looked at regional changes in gray matter atrophy in relationship to changes in T2 lesion load. And so in this particular study, they looked at differences in subgroups. So the top row are patients with relapsing or remitting MS. Second row are patients with secondary progressive MS. and the bottom row are patients with primary progressive MS. And I think an important finding in this particular study was that in the areas that are circled, these scans looked at differences between MS patients that were cognitively impaired and those that were cognitively preserved. And what they found was there were differences in the white matter in red and the gray matter in blue in specific areas that were regionally close to each other in relapsing remitting patients and secondary progressive patients, but they didn't see the same correlation between white matter and gray matter changes in patients with primary progressive MS. Now, if we look at a more regional well, so I think that one may speculate that that first comes a white matter lesion and then results in atrophy, through a Wallerian degeneration process.
Just because they're far apart doesn't mean it's not Wallerian degeneration.
But that's true as well.
But then why wouldn't they see it on the primary progressive?
Yeah,
Right.
I'm not sure.
It's easy
Yeah.
to imagine why there'd be the correspondence why they might be close.
Yeah.
But then, why would that subtype? What's different about the disease?
Yeah. Although I will mention that these are looking at differences between the cognitively impaired patients and the cognitive preserved patients. So it's less of a comparison between,
Not the disease
specific
type per se.
patients. Yeah.
Is it possible that it's the location of the lesion, that where you see the lesions, the gray and white matter lesions far apart, you're kind of in the middle of a superhighway, you're in the SLF, and so there that it has more of an impact, even if they're not proximal?
That probably is more of a regional phenomenon. Yeah, I think that's a good point. The white matter regional area that has been a focus in multiple sclerosis is the major white matter bundle that connects the two hemispheres called the corpus callosum. And there has been a predilection for involvement of not only T2 lesions within the corpus callosum in MS, but also thinning or atrophy of the corpus callosum. And so these are just two clinical scans from patients of mine showing evidence of corpus callosal lesions as well as significant atrophy or thinning. And there have been some studies that have correlated corpus callosal atrophy with things like interhemispheric processing, relaying both motor, sensory, and verbal information. And another nice study showed a relationship between atrophy of the corpus callosum and T2 lesions and also disability. And it's known that corpus callosal disease can happen very early in the disease. This is not thought to be something that only occurs late. So one study that I have done just very recently in collaboration with Rob Bakshi and Mohit Nima over at the Partners MS Center is looking at corpus callosal atrophy measures. In this case, we're looking at the area of the corpus callosum in patients that have been very well characterized with other atrophy measures, global atrophy measures of the gray matter and the white matter. This data will be presented in just 3 weeks at the ACTRMS meeting, which is the international MS meeting that occurs each fall. So we developed, made modifications on what has been done so far in determining corpus callosal area. So it becomes somewhat difficult to do volumetric measures of the corpus callosum because it can be difficult to determine where are the lateral boundaries. So what what we've done is to take high-resolution T1 images and resample them through the anterior commissure, posterior commissural line, and then do some intensity normalization, and then through an edge detection method determine the boundary of the mid-sagittal corpus callosum. And we looked at 38 relapsing remitting MS patients, and then also 21 age-matched healthy controls. And what we found was that there was a 20% decrease in the corpus callosal atrophy or area for MS compared to controls, which is similar to what has been seen in past studies. However, what was an interesting finding was that the effect size of the difference in the corpus callosal area was much greater than some of the other global atrophy measures. So things like brain parenchymal fraction, but also fractionation of the gray matter and the white matter. We correlated the corpus callosal area with the FLAIR lesion load and found a correlation indicating perhaps that the atrophy of the corpus callosum may be related to Wallerian degeneration. And then there was a trend towards correlation with EDSS. So in addition, we correlated the corpus callosal area with each of the global atrophy measures. So looking at gray matter atrophy and white matter atrophy in comparison to corpus callosal area. And what we found, very interestingly enough, was that the corpus callosal area correlated with gray matter fractionation, but it did not correlate with white matter fraction, which is interesting because the corpus callosum is a component of the white matter, indicating that there also may be, as far as etiology of the corpus callosal atrophy, degenerative process. So what I'd like to do now is to transition to some of the resting state studies that have been done in MS. And so resting state functional connectivity, there's some rationale for looking at the brain at rest, as a large percentage of the energy of the brain is consumed at rest. And this is I have about, I think, a couple hundred pictures of my daughter sleeping, and this one was probably the most interesting one, where she's in her stroller with one shoe off and legs crossed. So this was the best picture I had of someone at rest. So with resting state functional connectivity, we're looking at as opposed to task activation functional studies, we're looking at low frequency fluctuations that are seen and the correlation of those between distributed areas of the brain. There are a couple different ways of analyzing resting state studies. Some have used more of a seed-based approach, which I'll talk a little bit about, and then others have used an ICA or a component analysis. So as illustrated in this figure, with the resting state studies, you can place a seed, for instance, in this case, a seed is placed in the posterior cingulate. And there are fluctuations of blood oxygenation, or BOLD. And these frequencies can be correlated with every other voxel in the brain. And what has been found are there are areas with high correlation or synchrony, for instance, the medial prefrontal area, and then there are areas that are anti-correlated, for instance, the intraparietal sulcus, and because of this, we have found known distributed brain networks that where areas correlate with one another. And so this is thought to represent not only monosynaptic but also polysynaptic connections between brain regions, and therefore allow us to study distributed networks in the brain. So there are a couple studies looking at resting state in multiple sclerosis subjects. The first was done by Lowe et al. In 2002 in one of the first studies of resting state in general. And what that study showed was that there was a decrease in functional connectivity between homotopic regions in the sensorimotor network. Then Lowe went on in 2008 to do one of the first studies that tried to correlate anatomical connectivity to functional connectivity. So he looked at DTI in the corpus callosum in areas that were derived by tractography, and then compared that to functional connectivity by putting a seed in the primary motor cortex. And what he found was that the graph to the left is looking at a scatter plot of radial diffusivity on the x-axis and then functional connectivity on the y-axis. What he found was there was a significant correlation in MS patients between radial diffusivity and interhemispheric connectivity, but not in controls. This was a small group of subjects, though it should be mentioned. There were 11 MS patients and 10 controls, so small group. And then looking at FA, there was no significant correlation in either MS or control, but unusually when they combined the groups, there was a correlation. This is noted to be one of the few studies that have successfully, even though this may not be perfect, one of the few studies that have correlated anatomical and functional connectivity. So kind of piggybacking off of that work, we have looked at interhemispheric connectivity in patients that were recruited from the BI by Rip Kinkle and imaged by Caterina Mainero. And Caterina has been gracious enough to let me work with some of the data to look at things like interhemispheric connectivity, and then I'll go on to talk about local connectivity as new imaging biomarkers in multiple sclerosis. So what we have done first is to look at interhemispheric connectivity in the sensory motor network. And here are the demographics of 23 relapsing remitting patients. So average age of 39 and the fairly typical gender profile of 18 females, 5 males, an average EDSS of 2.5. So essentially that indicates that these patients have relatively mild disability on a scale that ranks from 0, meaning no physical findings on exam, to 10, which is death. To give you a sense of sort of the steps on that scale, an EDSS of around 2 means that patients may have some vibratory sensation loss in 3 extremities. That can give someone an EDSS of 2. If a patient has, in addition to that, some weakness in one extremity, that may give them an EDSS of 2.5. When patients go on to use an ambulatory assistance device like a cane, they would have an EDSS of 6. And if they're using a walker, then that would put them at 6.5. And then the average disease duration in these patients was 8 years. So what we did first was a very simple study of putting a seed in the left motor cortex and looking at then interhemispheric connectivity. So looking at connectivity to the right hemisphere, and this is a subtraction map where. Oh, thank you. So this is a subtraction map where we're looking at areas and plotted on caret, where areas of yellow and orange represent increased connectivity in MS patients compared to controls, whereas areas in blue represent increased connectivity in controls compared to MS patients. And so the homotopic region we can see has increased connectivity in MS patients. So not entirely what we expected, but as I'll show you, there may be some dynamic changes in these patients. Yep.
What's the scale?
And this scale is looking at raw connectivity. So it hasn't been normalized. Sometimes you'll see a Z scale that's 0 to 1. So this is raw data. Right. So they do vary. That's one of the hurdles, I think, of studying MS is that, and actually I don't have data to show you right now for things like lesion distribution, but one of the next steps would be to look at average lesion distributions in these patients, as well as also DTI maps, which would be helpful in showing not only specific lesions, but there are changes that we see on DTI in normal appearing areas or areas without T2 change. So I think that that's an important caveat with where the data is right now.
One more question?
Yeah.
Did you enter the functional connectivity maps with positive and negative correlations, and then look at the difference between controls and normals?
These are just positive correlations.
Just positive.
Yep.
That
Yep.
improves your interpretation or the ability to interpret. That's great.
Yeah.
And sorry, one more.
Yeah.
And this is just homologous points left and right? So you could get...
No, this is just one seed. So these aren't all. One of the next steps that we'd like to be able to do is to look at all homologous points in one hemisphere, or seeds in one hemisphere to their homologous point in the other hemisphere, and get more of an interhemispheric scale or score. The other thing that we did was then to combine a couple of these methods. So to look at corpus callosal atrophy measures using the same method that I showed before to determine the corpus callosal area and interhemispheric connectivity. So in this case, that's exactly where it would be potentially valuable to be able to look at potentially all homologous points and compare to a structure like the corpus callosum. In this case, we're looking at one seed to one homologous point. So we're looking at really just a finite connection compared to a more global corpus callosal area. So one approach is to broaden the functional connectivity, I think. The other approach potentially is to narrow the atrophy measures so it's more parcellated.
How do you define that homology, the left-right homology?
What's that?
How do you define the left-right homology?
Well, so in this case, we just took the negative MNI coordinate to the other hemisphere. And I think another improvement is to come up with a better registration method to look at that, which is something that we're working on. So one of the, I think, surprising findings, though, that came out of this, so our original hypothesis is that we would see some correlation between corpus callosal atrophy and interhemispheric connectivity. But in looking at the differences between MS patients and controls, what we found was that although there was increased connectivity in MS patients between primary motor areas, there was decreased connectivity between the primary motor area and actually the bilateral cerebellum and the anterior lobes and the vermis. And so I think this is potentially an interesting finding that deserves more exploration. So there was one other study looking not at resting state data, but functional data that showed that perhaps there was some decreases between motor areas and the cerebellum in MS patients. But there isn't really a lot in the literature looking at some of these functional connections. Now, there have been a couple papers that I wanted to highlight to sort of put some of our work in context that have looked at different differences in disease subtypes with regard to resting state studies. So there was one study published in Brain last year by the Amsterdam group looking at patients with the earliest form of MS. So patients with clinically isolated syndrome. And then they also studied a group of relapsing remitting patients and controls. And so what they found was that there was increased connectivity sorry, I should back up and say that they used the ICA method for regressing out the individual components and then took the 8 components of things like the sensory motor network, the default mode network, the dorsal attention network, the frontal parietal control networks, the executive functional network, and then things like the visual network. And what they found was that in the clinically isolated syndrome patients, there was increased connectivity in each of the networks except for the visual network. And what we can see here are, so in the executive function network, there was some increased connectivity in the medial prefrontal area, in the sensory motor, in the both of the premotor areas, and in the I'll also highlight the, you can see, I don't know if it shows up very well, in the posterior cingulate in the default mode network. There's increased connectivity in the CIS patients, but there were no differences in the relapsing or remitting patients compared to controls. So, yeah, go ahead.
Excuse me, I'm a little bit lost in this figure.
Sure.
But so the top row of, for instance, A is what the group members.
Yeah,
The
so.
second row is the group.
Yeah, sorry. So the top row just shows, I think the top row shows the CIS patients, so the activation just in the subgroup, and then the bottom row shows differences using SPM. So I think what this data indicates is that there is potentially dynamic changes the connectivity in networks in patients with MS. So at the very earliest stage, what we may be seeing is a sort of a functional reserve or a compensating mechanism in which connectivity is increased in the face of disease, and as lesion load increases, as degenerative changes increase, we see that that these changes decrease, as I'll show you with the next study. This just specifically goes into some of the data from that figure. What I'll highlight is that in the clinically isolated syndrome group, there was really no difference in controls between things like brain volume, gray matter volume, and there were decreases in those volumetric measures in the relapsing remitting patients. So another group looked at the default mode network in MS, specifically in progressive patients, as opposed to the previous study that just looked at patients with relapsing MS and clinically isolated syndrome. And so in this case, they looked at 24 healthy subjects, 33 patients with secondary progressive MS, so patients that had relapsing or remitting MS, but then progressed on to secondary progression, and then 24 patients with primary progressive MS. I'm going to skip through this real quick. So what they looked at was the default mode network, and what they found was that here are, they also looked at ICA analysis. What they found was that here the dark black bars are controls, and then the light gray bars are patients with primary progressive MS, and then the white bars are patients with secondary progressive MS. So what they found was that in specific areas of the default mode network, there were decreases in both secondary progressive MS and primary progressive MS, although the only difference that they found between the two groups was that there was a decrease in primary progressive MS in the ACC. So we haven't exactly put everything together in the case of looking at one study that's looked at relapsing or remitting patients compared to progressive patients, but I think that there is some suggestion that at least in these functional networks, the connectivity may originally increase and then decrease as time goes on, and that's supported by past activation studies in MS patients as well. And then I'd like to finish by talking about some more advanced metrics that the Randy Buckner lab has developed that we're starting to use in looking at patients with MS. So the Jorge Sepulcre looked at differences in connectivity between small world networks, meaning more local areas of connectivity, and then areas outside of those small world networks, or more distant connectivity measures. And they did a good job of defining a boundary of local connectivity that minimizes things like volume averaging, and then also is distinct enough that it does not represent larger areas. So they looked at various different radiuses for a sphere, and then looked at voxels, connectivity of voxels within that sphere. So in this case, the optimal radius was 14 millimeters, which includes approximately 3 voxels. from a particular seed region. And what they found was that there were definite differences as we look throughout the brain in areas between local connectivity and distant connectivity. Although there are some areas, interestingly, in the default mode network areas, such as the medial prefrontal, and that have both high local connectivity and high distant connectivity. And then there are areas that have a predilection for local connectivity, like the sensory motor areas, as well as the visual cortex. And so what we've done is to use those scripts to look at differences in local connectivity in patients with MS compared to controls. The point, I think, is to try to take a very focused determination of connectivity in order to measure the functional impact of a specific gray matter lesion. And then in the case of resting state connectivity, we regress out white matter signal, but there may also be some advantages to looking at some of these local connectivity measures actually within the white matter as well. So our initial stab at this is preliminary data looking at local connectivity maps plotted on Caret for 21 controls and 23 patients with MS. And when you're looking at a group of patients, I think specific, because MS is a heterogeneous disorder as far as the distribution of lesions and even potentially gray matter lesions as well, we may not expect to see changes in the group analysis. However, we did see some interesting decreases in local connectivity in patients with MS. So in the inferior parietal lobule and then areas of the dorsal prefrontal cortex, as well as the medial frontal cortex, there appears to be some decrease in this local connectivity. We see it actually to a somewhat greater extent in the right hemisphere compared to the left, but we also see it here as well. Also, there appears to be some changes in the insula. And what's interesting, I think, about this is that cortical lesions tend to be have a greater predilection for the frontal lobe and the insula. So there's some hints here that it's worth pursuing on a more discrete level of looking at cortical lesions and the effect on local connectivity. And that would be sort of the next step in looking at this measure. So what I think with this particular marker, we're hoping that it will tell us something about pathogenesis of the disease, but also maybe another marker that we can look at as far as looking at predictive benefit for patients. So I want to acknowledge Katerina Mainero, who's been a phenomenal collaborator since I've been here, and has allowed me to do some of this work with her on the data that she's collected. I also want to acknowledge Sean Tobine, who's a research assistant that's been doing a lot of this work furiously in the last couple months since he's been here. And then also Bruce Rosen, who has been a fabulous mentor since I've been here. I want to acknowledge some members of the Buckner group, including Kune, who's at the talk here today, but also Jorge, who has really helped me sort of, I don't have the specific numbers for as far as presentation in this group, but that may be something to look at. Yeah.
Any more questions?
Thank you very much.
Thank you.
Yeah, thank you.
Hi.
How's it going?